Good morning. Thank you for staying with us on Citizen Television. Daybreak it is. We appreciate you waking up with us and staying on the show until now. In case you're just joining us, health and lifestyle begins right now. And of course, we want to talk about infertility this morning. And we will be zeroing into polycystic ovarian syndrome. Many people call it PCOS, just to understand how it's connected to infertility, and also take this opportunity to explore other causes of infertility, an issue that affects not just women, men, but in our society, there's a lot of talk about how the burden has been placed on the women, but we'll be delving into just demystifying that particular, belief. And imagine just living in a world where childbearing is really held in high regard, and we live in a side of the world where voluntary childlessness has not been accepted. So you really can't hide the fact that you still do not have a child, and there's a lot that has been said, a lot that has been done against people who are in waiting, parents in waiting, I call them that. There's a lot of stigma going on and things that they've gone through, and we want to talk about all that, beginning from what causes infertility, all the way to options that are out there in case you're a parent in waiting, and why you don't need to give up. So karibu sana to the program. I'm having a panel of two, a lady and a gentleman, an expert and somebody who has lived the experience. So allow me introduce my panelists this morning. On the far right, we have with us this morning Dr. Kiriki Omanwa. He's a fertility expert. Thank you so much. Time. He's also the president of the Kenya Obstetrical Gynecological Society. This is usually a mouthful for me, but karibu sana to the program. And we have with us Lydia Ndiho. I choose to call her an infertility warrior because of the story she carries, and she'll be sharing with us a bit about what she's been through and where she is at today. Karibu sana.
Thank you, Safi.
It's good to have you both.
Asante sana.
All right. So today, let me admit, we are talking about a very sensitive subject, bearing, what people understand infertility to be out there in the society, and the misinformation that still exists, unfortunately. But let's begin by, first of all, just getting to hear from you, Daktari, as a way of opening up this conversation to demystify the myths that are out there when we are talking about infertility. What's the difference between infertility and those who are still just waiting, and you wouldn't call it infertility? So at what point does it become a case of infertility?
First of all, thank you very much for inviting us to the studio this morning to talk about this very sensitive, very stigmatized topic about infertility. You asked a very pertinent question. Yeah. What is the difference between infertility and those ones who are waiting, as it were? Infertility actually is defined in two ways. There are two types of infertility. The first type is what we call primary infertility, where by definition is that there is a couple in a relationship, doesn't matter what kind of relationship, and this couple have regular intercourse 2 to 3 times a week, and they have been trying to have a baby for a year, and it has not happened. Now, the ones who are just waiting, they are not in a relationship, so we cannot actually talk about infertility in these people who are waiting but are not in a relationship or are not trying to have a baby per se. This one, they are focused, trying to have a baby. There's regular intercourse 2 to 3 times a week, because there are some
unprotected.
They are not unprotected.
Any,
yes. Yeah. Thanks for raising that. It's unprotected intercourse 2 to 3 times a week, because there are some couples who have intercourse once every 2 months, for example, or once every 3 months. So then actually they don't fit into that description, that definition of infertility. And there's a small caveat to this definition, because if the lady is 35 years or more, then that waiting period of 1 year is actually shortened to 6 months. When you talk about secondary infertility, again, the same sort of parameters apply. A heterosexual couple in a relationship, regular unprotected intercourse 2 to 3 times a week, and they have been trying for a year, but for them, they have either had a baby or they have children, and they're trying to have another one, which has not happened, or they have had a pregnancy. That is the difference. And again, the same caveat applies, whereby if the lady is 35 or more, that waiting period is shortened to 6 months.
So they've had a pregnancy to mean there could be couples who don't have children, but they've had a miscarriage.
Yes, yes, that is still counted. That is still counted as secondary infertility.
All right.
Absolutely.
So, you know, we could talk about this all day, but we have with us in studio somebody who has lived through that. Even the stigma that I was talking about, the misinformation that I was talking about. You understand this, Lydia, from a very personal point. So let's begin here. You know, you have a long story, but let's begin here. So you're a young woman, you get married. Ordinarily, there's a script. You get married, you're excited, you want to have babies, you want to start a family. And then what happens?
And then it's not happening. And so, you know, you go see your guy.
How long into the marriage? So, so
for me,
for us,
for me, I wanted a baby immediately. Given I wanted to finish childbearing at a certain age. So I was like, you know, no, so I was not on any family planning plan. It was just, let's just get a baby first and then we'll sort the other things out. And then you go see your gyna and your gyna tells you maybe the problem is your timings. So you go through the whole biology class and it's still not happening. So I think for us, after trying all this, the first line, so you'll be given a few, so first they'll do the testing. So they did the testing. Most of the time they'll do the testing for the woman before the man.
Yeah.
I sometimes wonder why
don't even go
for that testing.
No, they don't.
In fact, I think
gynaecologists struggle for years trying to have a child and to realize that the man
he's never gone for the testing. So finally, after I am tested and I'm given all these drugs, is when the doctor says, wait, we've never tested him, so let's test him. So when he's tested, everything is okay. So now is when the doctor is trying to figure out why your hormones not balanced. We're doing all these tests and it's not happening. And then finally I get a diagnosis. I'm told you have PCOS. So I read about PCOS and I'm like, okay, on this spectrum, a lot of these symptoms I don't have, but it's okay. At least.
So this was your first interaction with even the term or the syndrome?
The syndrome.
So you're finding out.
You're finding out all these things at the same time. So this is like year 2 of marriage.
Okay.
And so we are now finding out all these things that we need to do. Finally, the doctor is like, I now surrender, I give up, let me recommend you to a fertility.
This after 2 years.
So this
so at what point, because you so many people would relate with your story because you've lived the experience. So you've been married, so after how long do you begin to feel, hey, something is funny? Because there are so many couples who get married and wanaambiwa ngojeni, mnaharakisha,
for me,
you know.
what made me pause is I increased weight gain. You know the way you gain weight to a point you're like, this is not normal.
Yeah.
And then you're not on, everyone assumes that you're on family planning.
So not on one.
Yeah. So someone points out and says, Lydia, you've gained a lot of weight. So, have you gone to see a doctor? So when I go see the doctor, in my mind, I'm just going for a checkup. I'm like, let me go see my gyna anyway. And then even him, he was like, hey, you've added a lot of weight. We need to test. Then I tell him, oh, by the way, my periods have not been coming on time. Then, so that's
by the way.
You know, it's
that's
by the way. The issue is
the weight.
The weight.
Yeah.
Because the painful periods that I had lived with all my life, I think I had painful periods from high school. And no one bothered to pause and think, why does this girl have painful periods? And then my periods are always long. They're not short. They're 6, 7, 8 days. I panic when they're at day 10. Like, that's when I'll panic. I'll be like, oh, there's a problem.
It's too much now.
It's too much. But now is when, after learning about PCOS, is when I've learned, even that high school girl who has very painful periods, someone needs to go take her to a gyna.
Just to check
as early as possible. Because if we had these checks, even when I was in uni, if we had done the checks a bit to find out, why does this girl have very painful periods? Are her hormones balanced? We would have caught at least a little of the syndrome before it manifests full-blown into something else.
All right. You know, one thing I'm learning is that in PCOS, in as much as it is a lifelong condition and that it's a common cause of infertility, still women who have it can get pregnant. And that is what you're saying. If it is and it's managed, in a better way early, then you can be able to have children when you want to have them. But we'll talk about that later. Dr. Listening to her and her diagnosis and how it came about, what are you getting in terms of what fits to the narrative of the challenges in women just getting to know that there is an issue of infertility here? Most of the time, we put belief that it will, you will get pregnant, you will get pregnant. And year 1 comes, year 2, year 3.
Yes.
People tell you it will happen, it happens. So year 5, year 10, the marriage collapses in some cases. So talk to us about what happens.
I think this is a problem, because usually when a couple gets married, the first thing they are prayed over for is that they may have children. I attended a wedding not too long ago where they prayed that the first child be a doctor, the second one be a lawyer, the third one an engineer, you know, that sort of thing.
Which is good.
So which is a good thing. But then the problem comes in when it doesn't happen. A year has passed, and you say, okay, a year maybe you're trying to understand each other. 2 years, kuna shida. 3 years, people start asking you, what is happening? Even your mother-in-law, sometimes some mother-in-laws are horrible. They start asking now, tutakuja kunywa uji lini? You know, when am I seeing, when are you giving me grandchildren? And all that. So pressure starts coming in. And usually the pressure starts from the immediate family and then from the society as at large. Why? Because we are socialized to know that you are called Mama so-and-so. So if that is not happening, the problem is you. We don't even think about the gentleman at all.
Men don't have a problem.
No, we don't have a problem. Tunasemaga mbele iko sawa. Wanaume ana shida. And these are some of the issues actually of the stigma which we actually need to confront. That the first year has passed, 2 years have passed, nothing is happening. So the first steps is to go to a doctor. What she did, her periods were irregular and long-lasting, number 1. 6, 7, 8, sometimes even 10 days, as you said. And then the weight gain. And you're not, and people think, if you're on weight gain and you just recently got married, then your husband is taking very good care of you, you know, which sometimes is not the truth. So when you talk about polycystic ovarian syndrome, as the name suggests, is a syndrome. So it has many symptoms, but then not all the patients will have all the symptoms. Most of the times, some of the patients actually don't have any symptoms at all. They get pregnant and, you know, they don't have any issues at all. And the polycystic ovarian syndrome is basically an incidental finding. They come with a different problem, and then when you do a scan, you find, hey, your ovaries are a certain, they have a certain structure, which actually, you know, confirms polycystic ovaries.
Maybe this would be a good point to break it down for us,
yes.
PCOS, just to understand what it is and how it affects the woman's body, and run us through some. She says she didn't have most of the symptoms that she was being told. So what are these? There could be somebody watching.
Absolutely, absolutely. When you talk about polycystic ovarian syndrome, it is where on the scan, when we do a scan, we find that the ovaries have small black areas, which some of them, which actually people define as having, you know, like these patients, not patients, but you know, these pearl necklaces that we wear, the ladies wear. So when you look at the ovaries, you will look as if they have that pearl necklace. Okay. Yes, basically,
and they are black.
And they are black. Okay. Yes, and there are many of them. Okay. Anything over 12 is actually indicative of polycystic ovarian syndrome. Now, it can be one-sided on one ovary, or it can be on both sides. Sometimes the ovary is very big, sometimes it's just normal size. This is an issue where the patient is born with this problem. It's not something that that happens, you know, because of medications, because of other things. Now, when you talk about a syndrome is where a patient has some symptoms. They could be 10 symptoms, for example, but a patient may have maybe 3 or 4 out of the 10 symptoms. When you talk about polycystic ovarian syndrome, where most of the patients have irregular periods. I had a patient who had a period once every 2 years. So for that one to get pregnant is practically impossible. So irregular periods, some have extra weight gain, you know, unexplained weight gain. Some of them are obese. They say, Dr. I'm eating normally, but I'm putting on so much weight and I don't understand. Some of them may have hair in places where it is not supposed to be, what we call hirsutism, where they may have hair around the nipples, around the abdomen.
And these are women.
These are women. On the upper lip, you know, some of them have a full-blown, you know, beard and mustache, you know, and they can be hairy as well. On the hands, you know, on the legs, generally, where women are supposed to be, you know, smooth-skinned, you know, and so on and so forth. Some of them start losing hair, what you call alopecia, which is, for men it is normal, but for women it is not supposed to be. And especially when they are young women, it can be very, very distressing. Acne is also another problem. And they have their skins, you know, on their face, they break out, sometimes even on the back, on the chest, you know, sometimes it can be quite stressing for them. Now, apart from that, they can also have issues like bloating, especially the time when they're supposed to have their periods. They are bloated, mood swings as well, low libido, you know, and so on and so forth. So most of the patients will not have all this together. You'll find a patient who is overweight, but does not have, for example, acne. But she's bloated, for example, and she's having issues with infertility. And actually, most of them come with infertility. I'm trying to have a baby, it's not happening. When you take the history, Madam, how heavy are you? I'm about 95 kilos. And how tall are you? I'm about this. So you find their BMI is a lot higher than it is supposed to be.
We're coming back for more on that, but then Lydia, so from what Dr. has shared in terms of the symptoms, so what did you present with apart from the weight gain? So, and then talk to me about your diagnosis with PCOS. At what point was it confirmed that it was that?
For me, it was the weight gain, and then I didn't have the acne, the hair, no, that I didn't have. It was the weight gain, and then now the bloating, the uncomfortable periods. Like my periods were for we sit down and a day off. You do nothing. You do nothing. You just tell your body pole. So because of that, so the periods were actually what was, the doctor was like, we need to scan. And so when you scan is when you see this, I usually call them the string of pearls around your ovaries. My ovaries are not enlarged, they're normal. It's just that you'll just see at a certain point, and then the scan usually has to be done at a certain point, because like for me, if I do it on a certain day, you'll find nothing.
They're okay.
Then do it 3 days later, the pearl is the string.
The when that
when
is done
also
is
important. And then the hormonal test, you'll have an imbalance of hormones somewhere.
Okay.
That hormonal test is usually, between the scan and the hormonal test, you will know for sure there's a problem. So
it is diagnosed by a series of tests, not just one, a linear test.
Number one is when the patient comes, the history.
Okay.
When I take the history, I'll have almost 50–70% diagnosis what I'm dealing with. Because when you ask about the periods, whether they're regular, they're irregular, how long do they take, most of the patients come and say, my periods are irregular. That is already a red flag. How irregular are they? Sometimes I have a cycle of maybe days, sometimes it goes to 120 days. That is not normal. That is already abnormal. And then again, when a patient comes, you can also see as she walks into the consultation room, you have this sixth or seventh sense. You can look at the way she's coming in, she's talking, you sort of have an idea what it is. So we have taken the history. I sort of have 60–70% chance that this is what I'm dealing with. The next thing is to do an ultrasound scan, a transvaginal ultrasound scan. And then when you do that, that scan this is a beautiful picture, that, you know, pearl necklace sort of picture, then it's basically a confirmation. Now, if you have irregular periods and you have that pearl necklace, you know, sort of picture, it's already a confirmation. You can also do a hormone test just to check. Sometimes the hormone tests are okay, but now that picture that you saw and also the history that the patient gave you.
All right. So you've talked about irregular periods, which is quite common among so many women. So one would be scared. So if I have irregular periods, then I have PCOS. And then when you talk about hormones, also talk to us about which hormones and what levels are they supposed to be, and somebody who is presenting with PCOS, what is their hormonal situation looking like?
You see, when you talk about regular periods, periods depending on because all women are not the same. Every woman is different. There are some who come and say, my cycles are 21 days. But when they go 5 days, for her, they are irregular. But for us as gynecologists, they are still regular. They will be irregular when they cross, maybe they go to 35 days, you know, 40 days, that is irregular. Or when they become very often, you know, every 2 weeks or less than 2 weeks, then that is also a challenge. When it comes to infertility in general, and when we are trying to find out what the problem is, there are hormones which are very, very basic, which we have to look at. The first three hormones are one we call TSH, T for Tom, S for Simon, and H for Hilda. That is a thyroid stimulating hormone. These are hormones which are produced by the thyroid gland, which is a gland which is just in front of the voice box. A very, very important gland. Why? Because I normally call it the manager of other hormones in the body. If you find that the TSH is elevated or is lower than it's supposed to be, it is going to affect the way the body behaves normally, and then it will also affect the reproductive process. There is a hormone called PRL. Peter, Robert, and L is for Lydia. Prolactin. Prolactin is a hormone which plays a huge role, especially in women, because when a woman is expectant, prolactin tells the breasts to start getting ready and to start producing milk. Why? Because there is somebody who is going to make use of this food which is being prepared. However, sometimes that prolactin can be elevated even if there is no pregnancy. For example, stress can increase the prolactin level. For example, a growth in the brain can also increase the prolactin level. So the fact that prolactin level is elevated does not necessarily mean that a woman is expectant. And especially if they are trying to have a baby, that is a red sign that something is not okay. The other hormone that we check is called AMH. Martin and Hubbard, for example, AMH. It's called anti or anti-Müllerian hormone, depending on which school you went to. Ukienda a group of schools, you can call it anti-Müllerian or anti-Müllerian hormone. This is a hormone which tells us about the ovarian reserve. What exactly is ovarian reserve? It doesn't tell us that this lady actually has, let's say, 300,000 eggs or 500,000 eggs, but it tells us that if this level is high, then the reserve, the number of eggs that is remaining, is a good number or is a low number. It can be affected by different things. For example, age is a factor. You remember we talked about 35 years or below. Why? Because usually ladies start having their periods around 13, 14 years. And then by the time they get to 35, you'll have had periods for around 22, 23, 24 years. So that number of eggs has reduced because remember, every time a woman has a period, she loses a number of eggs. So by the time she gets to 35 or more, that number has drastically reduced. So that is why AMH is very, very important. However, sometimes we see young ladies who have a very low AMH because unfortunately, that is the way they were born. It's constitution, it's genetic. For example, in the family, the auntie, the mother also had issues like that, and so on. Treatment can actually affect AMH. For example, in patients who undergo chemotherapy or radiotherapy, patients who undergo surgery, if they have a growth on the ovary or on ovaries, and then if we are not very judicious when we are removing that growth, we may remove with a lot of normal ovarian tissue, and that will reduce the ovarian reserve, as it were.
I'm coming back to you because I know there's still more. I was curious specifically also on the hormone that makes women to have hair in areas that are particularly not,
Yes. Now,
but
normally women have hair in different places, but what makes them have hair in places where they are not supposed to is called testosterone, and that is the hormone which makes men men. In that we have hair in different places, we have on the chin, and so on and so forth. Now, sometimes even that testosterone can be the normal level, but they are what we call receptors. And these receptors in women are more sensitive, again, because of that polycystic ovarian syndrome. They are more sensitive to these levels of circulating testosterone in the female body. So these women will have hair where it is not supposed to be because of that improper functioning of the ovaries, because of the polycystic ovaries.
All right. Thank you for taking us through that, breakdown. But I want to understand from Lydia. So your journey took how long, and what was happening within those years? It must have been one of the most difficult seasons in life as a woman. So run me through just that journey of being a parent in waiting in this part of the world.
Oh, first, the questions. I think the questions are what usually used to drive me crazy, because you see, you're also doing fertility treatments. So the fertility treatments mess around with not your hormones, your mood swings. You cry at any time. You're just miserable, and then
you can't control it.
No, and then on top of that, it's timed. Doc will give you a schedule of when you should be injecting yourself with a hormone, because you're either trying to retrieve eggs or there's something going on in your life at that point. So for these 6 years, it's very intense, and then everyone is asking you very weird questions.
So it took 6 years.
Yes,
it took 6 years.
For us guys 6 years as we were waiting. So it gets to a point someone is making snide remarks, and you're thinking, oh, not today, Jesus. Like, it's draining for you as a woman, because first you can't control.
Ever had nyinyi wanawake mmesoma siku hizi, you don't want to
have children, mnajaza choo za wazee wenyu na instead of giving birth, what are you doing? You're just eating your husband's money. What they forget is they need to ask you where you're at. Because at that point where you're telling me all these things, I am collapsing inside. You see, it's a very personal journey. There's no one with you in hospital when you go for example, at some point I used to go for jabs every morning.
Nobody is seeing this silent battle.
No. See, you go for the jab, and then you go to work.
Yeah.
No one is seeing the things going on, if I'm going for a function, I have to think, at some point I used to do an injection in the morning and in the evening at 8. So that 8 p.m., I have to walk out of whichever function I am in and do the injection, because if you miss it, doc will have a serious tongue lashing at you for missing the jab, which is...
It has to be done at that time.
Timed. Yeah. You're given a schedule and it's very timed. So at that point, Safin, you don't have the capacity to deal with people's snide remarks. That one, she decided she wants to stay with a kafiga. She doesn't want children. And then people stop inviting you for things.
Baby showers,
weddings, especially baby showers. And I'm like, why you? And birthdays. Invite me for your baby's birthday. If that day I don't have capacity to handle it, I won't come. But invite me. Then all of a sudden your friends become they don't know what to tell you, which I understand. But presence also works. Presence is also a gift that you need to But you hear comments of, she got married and she decided not to have children. She, like, it's
People
there.
say all sorts of things.
People say all sorts of things. Oh, she's refused to get off family planning. Family planning is destroying marriages.
Or she did something when she was young.
Oh, yeah. Oh, that one. She had abortions, and that is why she can't have a child. I mean, people have theories. And then there's the mitishambas. People will give you ideas. There's a mitishamba that I can send you. Then others will give you the most hilarious one was, my brother can give you a child.
Oh,
like,
okay. So you
went
through all this.
Yes.
But what kept you going? What kept you on the course?
Because I wanted a child. I think I was very focused. I thank God I was very focused. Like, I was like, I want a child. However, it is very hard. Then truthfully, there's also support systems. We have waiting rooms. It's an association on Facebook. You'll find them where couples who are waiting, we have discussions and encourage each other. So there has to be also a support system. I have some girls that are just my friends who we just walk this journey together with. We exchange ideas. Dr. Kireki has even visited us to give us stories, to give us a talk. So we have those support systems, but it is hard. And especially if you're in shags, in the rural areas, the victimization is a lot more.
All right. So, Daktari, enlighten us today. We don't want to get out of this conversation thinking that it's caused by uchawi, witchcraft, all those things people say out there. What are the causes of infertility? And also you can zero into PCOS, because since that's what we are mainly focusing on this morning, what causes it?
Thank you. Thank you, first of all, for saying that it's caused by uchawi, mamamukwe.
That's what people think. And a lot of it misinformation that goes out there.
And all that. And I've actually met patients who come and say, you know what, I'm talking to you today, and they were very frank. Alafu baadaye, nitaenda kuona mganga, that sort of thing, which is they're within their rights, to do that. But I think most of the time is that what we cannot identify and put, sort of a reason why we attribute it to mitishamba, uchawi, and so on and so forth. Now, when you talk about causes of infertility, we can divide them, causes which affect women and causes which affect men. We'll start with the ladies. There are more ladies here today.
Okay. Now,
remember I talked about age. Age is a very big factor when it comes to infertility. We saw this in the UK, where I was working before I came here, where you find that quite a number of the patients that we dealt with were over 38, 40, and so on. Why? Because they have gone to school, and because of the struggle that women have to get the pinnacles of their careers, and once they get to the top of their careers is when they decide, now we want to have a baby. Yeah. We have the prestige, we have the money, but we don't have a family. So when they come now, you remember the hormone I mentioned, AMH. When you check the AMH, you find the AMH is drastically reduced, meaning that the number of eggs which are still remaining is low. And apart from that, the quality of the eggs that we'll get will be poorer, meaning that the quality of the embryos that we'll create will also be poorer, meaning that even when we transfer these embryos, the chances of them actually implanting and having a baby, a normal baby, are also quite reduced.
So what are you saying? The earlier the better?
The earlier the better. That is what we are saying. If you can, the earlier the better. If you haven't got Mr. Right, well, we can actually freeze the eggs for you, for the ladies, and then until the time when they feel that they have the right person, then they can actually come and we create embryos with those frozen eggs. If you freeze eggs at, let's say, 28 years, they will remain in that state for 5, 10, 15, 20 years. So it will increase their chances later on of actually getting pregnant.
So age is one of them.
Age is the biggest factor. Is one of the factors. We have issues with blocked tubes, and I see these on an everyday basis with all the patients, most of the patients that I see. We may have tube which is blocked on one side, or both sides are blocked, or the tube, a tube has fluid in it, what we call hydrosalpinx, or both tubes have fluid, or they are stuck, for example, to the pelvic side walls. So normally tubes are supposed to make that kind of movement because they pick the egg and push it, into the tube as it was, so that it can be able to meet with the sperm. So if the tubes are not functional, then the chances of getting pregnant are also reduced. And most of the time, you may find these patients will have what you call an ectopic pregnancy because of that lack of proper movement of the tube. We have issues with growths in the womb, what we call fibroids. 40 to 70% of women of African origin, irrespective of where they are, will have fibroids in their reproductive period. And women of African origin have huge fibroids. I've removed a 6-kilo fibroid. My colleague,
the size of a baby.
They can actually be two babies.
Twins,
actually, yes. My colleague removed 140 fibroids from a womb. But he said, when I met him not too long ago, he said that's not the record. Somebody else removed 144 fibroids. So fibroids will distort the uterus, it will distort the cavity, that is where the baby implants and grows, and it will actually be a reason for infertility. We talked about polycystic ovarian syndrome. Affects about 10 to 15% of women who are in their reproductive period who are actually to get pregnant. And as I said, because of the number of eggs which is there, the ovaries are not functioning the way they should. That is why you have an imbalance of hormones which you had, and these can contribute to the irregularity of the period. And because the periods are irregular, very difficult to time when to have intercourse so that to have a baby. We have a problem with what we call endometriosis, where we find a bit of the lining of the womb. What out when a woman is having a period can actually implant elsewhere, can actually get stuck somewhere else, and then it will start behaving like that lining. It grows when just before the periods, and then during the periods it also sheds. And so on. A very big problem not only in this country, because it affects, as I said, about 10-15% of women as well.
Let me take you back to the PCOS. Is it hereditary? That was a question that somebody wanted. Just a clarification. Is it hereditary?
You see, when you talk about hereditary, it means that we have to have a gene which is directly linked to that disease. Disease like sickle cell anemia, where the red blood cells change shape. This is a genetic or a hereditary disease, meaning it can be passed on from one parent to the other. Now, in case of polycystic ovarian syndrome, we have not identified a gene such that when this gene is present, we know that the girls in that family, percentages-wise or whatever it is, will actually have polycystic ovarian syndrome. So there is something that is called familial. It runs in the family, but not necessarily genetic, as it were. Okay? Right. Now, we have issues with hormones as well, when the hormones are all over the place. If the TSH is elevated, for example, and you may have a challenge, in getting pregnant. Prolactin is elevated, you may have a problem, in getting pregnant, and so on. Lack of intercourse, that is also another problem. When you have patients who are trying to have a baby, remember the definition we talked about, that it has to be regular intercourse 2 to 3 times a week. Now, we see cases, for example, because of economic situation, you find the men are out there working. They home once 2 weeks or 3 weeks in a year, and they may come when the lady is having a period. So even if they are trying to have a baby, that one will not happen. Now, what we eat and how we eat it. You see, when you get married, soon after that, we want our ladies to look nice. They put on a bit of weight, and the gentlemen also, because then they say, "Allah, Kwani, your wife is not taking care of you." That sort of thing. Now,
so you have to gain a
bit
of marriage to seem as
exactly.
working. Yeah.
Now, if you put on a bit of weight, the gentleman has a bit of public opinion, as it were, and the lady has put on a bit of weight. When it comes to having intercourse, it can be a challenge because imagine there's a bit of weight in the front for the man and for the lady. So it's like having intercourse with 2 pillows in front. So you may not get to where you're supposed to get, and so on. Stress is also something which affects the fertility. However, we are not able to quantify how much stress, because we see couples, they have tried, everything is fine. Na haifiki. Kabisa. And then they go and adopt a baby, for example, and as soon as they adopt a baby,
start enjoying and celebrating.
Actually, they forget about it. 2-3 months,
they are pregnant.
So it means there was stress, a huge amount of stress, and now that stress is sort of out of the way, and the body is now functioning normally, and they get pregnant. For the men, the biggest challenge is the quality of the sperm that we get. So we may have sperm. We may have an ejaculate, let me put it that way. An ejaculate is basically what the men give us to go and analyze. You may get an ejaculate where there are no sperms, meaning what we call azoospermia. Sometimes it's because the tubes where the sperms pass through in order to get to the urethra and then to come out, those tubes are blocked. So where the sperms can't come out, but when a man has intercourse, he gives an ejaculate. But what comes out is what you call seminal fluid from the prostate gland. So this is what people call, shooting blanks, as it were. A very unfortunate, sort of term. So sometimes you find
very demeaning.
Very demeaning.
Very demeaning.
Very, very demeaning. Sometimes you find that the number of sperms is reduced because of different reasons. Smoking, for example, may have an infection, for example, and so on. The quality of that sperm, the ones which are normal, can also be reduced. The number of sperms can also be reduced. The way they swim can also be reduced. Or sometimes you have all of this. You have the number is reduced, the motility, the way they swim is reduced, the normal forms are also reduced, and so on.
All right. Sorry to take you a bit fast, because we want to at least give people hope.
Yes.
Before you wind up. But let me hear from you, Lydia. At what point did your story change and what options were put on the table for you? Today you are a mother.
Yes.
Yeah?
Yes.
You are a mother.
Yes.
Despite all that you went through, despite the struggle, the name calling, the advices that were coming from left, right, and center, finally you achieved, whatever your heart's desire was. So how did that happen?
So for me, I adopted. I went the adoption route. You can, there's so many. Choose, Daktari will give you IVF, IUI, and any other medically assisted reproductive method you can use. But for me, I chose adoption.
Okay.
I was tired, my body was tired, my mind was tired. I was just like, what do I really want? To be a mother. There must be a child somewhere who needs a mother.
And you need a child.
And I need a child. Yeah. So the blessing came in through adoption. She's now 9 years old, the most vibrant human being you will ever meet. She looks a lot like me, which everyone doesn't believe that she's adopted. If you meet us, you will not believe that story.
Mother, daughter. But that's what you are.
But that's what we are. We're mother, daughter. In fact, there are times I forget that it takes a while for me to remember that she's adopted until when now I have to give a history of like a medical history. Then I'm like, oh yeah, I didn't get pregnant. But that apart from
so for
that,
people who are watching you and they've ever thought about going that direction, but then again, the fear and the questions. How did you deal with that feeling of you want your very own? That's what Africans want.
Yes. So there's the fact that you'll have to accept that this has not gone the way you want it to go. But a child, and you will love this child. But you have to come to a point where you accept that this has not gone the way you want it to go. If you have not accepted, then adoption might not be your answer.
Your solution.
Because you will still chase that dream of, I want a child, I want a child, I want a child. I'm at the point in my life where if I get pregnant, it's a miracle, wow, it's okay. Good. But
if it doesn't,
I'm still a mother. But for that lady who is at the point where she's not yet given up on the hope, on the dream, don't yet. Don't go for adoption thinking it will fix that part of you that really wants your own, to carry your own baby. It won't. I need to be clear. So it's like that dream has to end, and you're very clear that it's okay,
even if it never happens. That's when now you're ready for adoption.
Yes. Otherwise, you will adopt, but you will still be chasing this pregnancy, so you'll still be unhappy. Yeah.
Okay.
Yeah.
Okay,
I think that's what I would like to remind people. And adoption is beautiful. It's motherhood. I usually say my daughter cured me of all hang-ups of motherhood. We have done everything from being in hospital in the middle of the night to crying to... We have had the whole works. So it's motherhood. It's just a different route of motherhood. And I think the journey must be done. You must go through the journey.
So Daktari, adoption is one option.
Yes.
So what other options are there? So for somebody who is a parent in waiting, they are watching this conversation, they're wondering, okay.
There are very many options. And what I want to emphasize here is that there is hope. And that hope is here in Kenya. You don't have to go to the US, you don't have to go to South Africa, to India, wherever it is. The hope is right here. What options do we have? First of all, we need to exactly understand what the problem is. Sometimes actually it doesn't need a lot. Just need a little bit of tweaking, a bit of tablets here, and hey presto, you have, you get you correct your hormonal imbalance, for example, and then, and everything.
She was told it won't take 1 year.
No, me I was told it would be like this.
Hakuna shida, it won't take 1 year. 7 years later,
the doctor was like, Lydia, your problems are so few. Because I think he had seen worse cases of PCOS,
yes,
and they had gotten pregnant. So for him, he was like, this is a pill.
All right.
And then
and I think that is why the treatment has to be individualized.
Yeah.
We can't say this size, one size fits all of them. So we have known what the problem is. For example, if the problem is with the man, and by the way, about 40% or slightly over 40% of the reasons of infertility actually affect us men. So I want to make an appeal to men. Please come for those tests, and the tests are very simple. It's just to give a sample and we check it, and we'll know what the problem is. We can give medications for the gentleman, and you find the parameters have increased, and all of a sudden you find everything is okay. But we have to cross that stigma. We have to cross that boundary, that border that is actually stopping the men from coming for examination and treatment. If the issue, for example, is with blocked tubes, especially for the women, we can try and do surgery, which doesn't help a lot. In that case, then the only option that we have is to do IVF. Sometimes the tubes are okay. The problem is with the man. We can do what is called IUI, meaning we prepare the patient, do what is called follicular tracking, make sure that she will be at the right time. There will be an egg which is ready to be released, and then the gentleman gives us the sample, we clean it, and then we inject it into the womb. And it also does help. If that doesn't help, then of course we have the fallback position, which is IVF. And IVF basically is called in vitro fertilization. It's a generic term whereby we create a baby, because an embryo is the beginning of a baby. We create a baby in the lab. How does that happen? She talked about injections. We start giving the patient injections from day 1 of her period, day 1 or day 2 of her periods, for about 10 to 14 days. We take her to theater. We remove eggs. We are not cutting anywhere. We remove eggs from through the vagina. And once we have those eggs, we have to work very closely with a scientist called an embryologist. So he or she will look at the eggs, we'll get the sperm, and then I can see you have a very beautiful picture there. It's beautiful. So we take that sperm and actually inject it into the egg, and then we put these fertilized eggs in what you call an incubator, constant temperature, and they will start growing and dividing. After about 3 to 5 days of growth, we will do what is called an embryo transfer. We take 1 to 3 embryos and transfer them into the patient's womb, give her medications, because remember, this is an artificial cycle because we've been manipulating the cycle with medications. So we will have to give our medications to help to support those embryos that we have transferred. And then we have actually, science has also helped us quite a lot because we are able to diagnose. You asked about whether PCOS is a disease which is genetic. We can be able to identify genetic diseases in the parents and be able to identify which of the embryos has a problem, and then those ones we don't transfer. For example, sickle cell anemia, we can say this embryo
during the IVF process.
Yes, during the IVF process. Embryo number 1, number 5, number 7, this one are sick, they are not okay because they have the sickle cell anemia, but embryo number 2, number 4, number 6 are okay. So these ones
it can be used to sort of like stop the hereditary.
Correct.
IVF.
Correct, absolutely.
And you can choose gender.
Oh, yes, we can. Yes, we
All
can.
right. I know I wish we had more time for this conversation. There's still a lot that we could explore, but we will get another opportunity.
No
Unfortunately,
problem.
we've run out of time. I'd like to give you 30 seconds each for your closing remarks. For you, I'd like you to speak to just our couples in waiting and just tell them whatever it is that is in your heart right now to tell them. And then, Daktari, you can also close with your closing remarks.
Okay. For me, I'd say there's hope. There's a lot of hope. Get checked. As a couple, don't give up. Get checked. Go see your fertility specialist. Come up with a plan. I know it is expensive, so also save for it. Save for it.
Oh, yeah.
Save for it, but don't give up. And don't give up on the marriage. It will work out. Yeah.
It is expensive.
It is expensive.
Daktari?
Thank you. It's good that you mentioned about expense. So I'll make an appeal to SHA to help these couples who have this challenge. If they can be able to subsidize some of the costs, that would be fantastic. It will make it more available to the couples who are struggling. That is number 1. There is hope because the technology, the knowledge, the skills and ability is available in Kenya. There's no point of going outside the country. And then number 3, I'm available. This is something which we have trained in the UK and other places. This knowledge is available. My office is at 5th Avenue, 5th Ngong Avenue offices, 3rd floor 314. I'm available and I'm here to help all the couples who have these challenges.
Asante sana, Dr. Kireki Omanwa, fertility expert, also the president of the Kenya Obstetrical Gynecological Society. We were also talking to Lydia Ndiho, an infertility warrior. She has a story to tell, but today she's a mother. She's happy, she feels fulfilled, and she's telling couples who are parents in waiting out there that there is hope. Don't give up. Don't give up on your marriage. Don't give up on your families. There is hope. But then again, let me just put a disclaimer out there. This information, this show is for information purposes only. Don't take this as a diagnosis or as a prescription on what you need to do. Please visit so that you can get your individualized case looked at and you're given your own individual plan so that you can walk that journey to parenthood. It is possible. Don't give up. My name is Safin Achieng Oma. Thank you so much for watching the show this morning. It's a wrap for us, but keep watching Citizen Television.